Welcome back to episode 20 of the Rehab Exercise and Sports Therapy podcast. I am really excited today to be joined by Dr. Kyle Kimbrell from Owens Recovery Science to discuss all things blood flow restriction. Blood flow restriction is obviously a newer modality, but tons of applications. So I am very excited today to discuss all the kind of nitty-gritty details from something that I know is daunting to a lot of clinicians. So I want to kind of treat today as kind of a primer for clinicians that may not be as familiar with how to use blood flow restriction or integrate it into their clinical practice. If you enjoy any of the podcast content today, please consider liking, subscribing, and or reposting any of the content, any social media outlets. Kyle, if you don't mind, I'll let you give a little bit of background about what you do professionally at this point, and how how you came to be kind of the blood flow restriction guru here, if you don't mind.
Sure. The guru without the robes and
Yeah,
beads
exactly.
and incense
Right.
and all
Yeah.
that. Yeah, I suppose that kind of is where I fit now, strangely enough. So I'm a physical therapist by trade and practiced in outpatient physical therapy for 15, 16 years, somewhere in that neighborhood. In about the last 3 years of that, I had taken Johnny Owen's course. We actually had him come to our clinic in Southern California and teach us BFR, and got very, very interested in the technique, in kind of helping it grow within the rehab space, that kind of thing. There was loads of opportunity for that at the time in the greater Los Angeles area where I live. And so that kind of snowballed into Johnny needing somebody to go do an in-service for this sports team or that college or what have you. And then that kind of snowballed into various different clinics here and there. And eventually I started teaching the content for Owens. So now I've been teaching BFR during weekend courses now for about 7-8 years, somewhere in there.
Wow. Okay.
I
Yeah.
haven't totaled it all up. I know I'm well over 150 day-long courses taught at this point, which is kind of hard to wrap your head around when you just think about the amount of talking.
Yeah, right.
and it seems like it happened in the blink of an eye. So now I left the clinic in the spring of 2019 and started working full-time for Owens. So a lot of my responsibilities are just kind of generating content for people to consume. We have a podcast that we do on about a monthly basis. We're up to about 70 episodes now. And we bring on researchers, and then we also bring in kind of our core teaching group and break down papers and things like that. Yeah. So we have that. So I manage that, do a lot of just kind of day-to-day operation stuff that involves marketing and setting up more and more classes just kind of around the US, and then just generally serve as kind of an expert for people to talk to on BFR if they are needing some help. Kind of a lot of times we're helping people with just that decision-making process of whether or not to use it or not. And you're never trying to tell somebody absolutely you should use this, but
to use it.
Sometimes there are circumstances where it's like, man, this person really sounds like a really good candidate. Like I don't think you should be nervous about it. But it being, like you said in the intro there, it is newer, and there's still a lot of questions around it. There's still questions that I have around it. So, but yeah, that's kind of me in a nutshell. I think we just spoke at CSM, so we do a lot of that, a lot of writing, a lot of speaking outside of our courses. And
that must have been great. It's like home base for you, right?
It was nice.
Yeah, right. Yeah, right.
It was nice not to
next
have to
year a little more travel and trek, right? Yeah.
That's an entire day of travel when you go West Coast to East Coast. Right. As I'm sure I got to do that next month. I'm going to Daytona Beach to teach, and it's going to be a whole day of travel.
All right.
on either end. Yep.
So, and you're a smart man. You got out of the clinic before COVID and a lot of the other stuff. So
Yeah, I don't know if
right.
that was intelligence or just luck, but I was very thankful to not be in the clinic during COVID. Of course, there was the flip side where we didn't get to have any classes or anything.
Wow,
so,
right, yeah.
I was sitting at home going, man, what do I do to keep this job? I kind of like this job. I want to, I got to make myself valuable here, so you're just kind of looking for little things to kind of up your game and make you look more valuable.
a lot of pumping out content during that time.
Yeah, exactly. Exactly.
So, Kyle, if you could tell us, I know blood flow restriction was originally developed from Katsu, right, from Japan. So if you could just give us a little bit of kind of the history and background with kind of the popularization of blood flow restriction.
Sure. I kind of push back on the history narrative that's out there that it began with Katsu personally.
Okay.
Only because, if you look back in these papers and you kind of trace back references, there's plenty of references of people doing a BFR-like kind of stimulus prior to Katsu. Katsu, what they deserve credit for is developing a device specifically for this technique and then using it primarily to increase muscle size and muscle strength. But the technique was kind of already there. I went back as far as 1872 to a guy named Julius Conheim, who, interestingly enough, was studying venous thromboembolus. And he was at University of Berlin with a guy named Rudolf Virchow, which we actually are familiar with Virchow because he came up with Virchow's triad, which is basically the kind of 30,000-foot view of how to sort of stratify whether or not somebody's going to form a clot. So he came up with this idea of endothelial tissue damage, stasis, and hypercoagulability. Those are his. That's his kind of triad. So anyway, Conheim was working in that same lab with him, and one of the things that they were doing is actually putting tourniquets on people's limbs and leaving them for a period of time and then letting them go. And Conheim noted that when you let the tourniquet go, you got this really kind of crazy color change in the limb, which he called reactive hyperemia. And of course, we know now that's really just kind of an increase in blood flow into kind of these peripheral tissues. You see it when you exercise and that sort of thing. So he ultimately kind of dubbed that, and then you fast forward a little bit to kind of the early 1900s, and a guy named August Beer starts to use this technique to treat various different medical conditions. And then really, from my perspective, what I kind of think of as the first true sort of BFR experiment, paper, whatever, happened in 1936 with a couple named Allam and Smirk. They were examining the exercise pressor reflex. And so they were curious, why does blood pressure and heart rate increase when we exercise? And so one of the things that they did was they put a tourniquet on the thigh, they inflated it to just above systolic blood pressure, and they had people do a soleus type exercise with that cuff inflated. And then they measured their blood pressure, and they basically saw that blood pressure, of course, went up when they did the exercise and went up a little bit more when they added the tourniquet. And it actually stayed elevated if they left the tourniquet inflated upon stopping exercise. So interesting, that the blood pressure didn't go down when we stopped exercise. The tourniquet's having some sort of an effect there, if you will. Could be mechanical deformation of tissues, could just be that venous occlusion is kind of trapping metabolites, or probably just a combination of both. And so then they do, another experiment where they leave the tourniquet on for say 3 to 4 minutes after the exercise is stopped, and they actually find that blood pressure goes up again. So again, just kind of that, inactivity, whatever's kind of happening in that limb, the duration of it seems to kind of matter as well. So then we kind of fast forward, and there's a lot of different just kind of little studies until really Katsu's first papers are published like late 90s, somewhere in there. They kind of tell the narrative of the idea happening in the 60s, but they don't publish anything until the early or late 90s. And there are multiple BFR papers well prior to that study things like mechanistic approaches and whatnot. So from Katsu, it just kind of sits for a while, it feels like, because those papers start coming out, late 90s. And of course, I think people were probably talking about the work somewhere in there. You get into kind of around 2006, the Journal of Applied Physiology starts reviewing the Katsu papers, because Katsu developed its own journal because they couldn't get their papers published
Oh,
in
okay.
like US journals and higher tier journals. And they were cranking out a lot of research and nobody's publishing it. So they just developed their own journal to publish in. And so the Journal of Applied Physiology goes to this renowned exercise physiologist at Michigan State, Dr. Meyer, and they say, hey, could you review these papers and just tell us, is this something that we should even kind of look at?
Yeah.
And so he does, and he basically kind of says, it looks like what this technique is helping people identify is that when you resistance train, it's not so much that you have to lift heavy. What's really important is you need to get anaerobic. And
Right.
if you can get anaerobic, then it looks like you can induce some fatigue, and that fatigue ultimately leads to increases in muscle size and muscle strength. So from there, that was 2006. That review was done. Somewhere in there, you have guys like Jeremy Lineker and Stephen Patterson are doing master's work and PhD work, really kind of expanding the field. There's plenty of other researchers kind of around the world that have started to look at this. And then you get into around 2010, 2011. That's when our company's founder, Johnny Owens, who was working within the Department of Defense, starts to look at BFR as a way to help address muscle strength deficits in blast trauma victims, to basically to help them be able to use a really fancy AFO that they had developed. And so he gets involved. His process to get there was they got guys that are literally cutting off their legs because they couldn't use this device that they had developed. And they developed the device because people were cutting off their legs that they had saved. And so, they were just searching for a solution, and they needed a solution that could increase muscle size or quality and quantity, muscle strength, and, also help these people be able to use this brace that they had developed. And they came across BFR. So they talked to everybody. They talked to Patterson, they talked to Lineker, et cetera, looking for, what are the best ways to do this. They test all kind of different ways at Center for the Intrepid. And ultimately what ends up happening is Delphi, who is a tourniquet manufacturer and then has like a research arm as well that researches tourniquets, they come along because they had developed a really small tourniquet device that was going to be used to help transport service members back from the battlefield that had been blown up, basically, these blast trauma victims that Johnny's working with. And so they come along, and the tourniquet researcher at Brooke Army Medical Center, where Johnny is, he's a colonel. I forget his last name, or I would mention it. But Colonel Craig, I think it was Colonel Craig. He's meeting with all the Delphi people, and he's like, you guys should really see what we're doing with your tourniquets in rehab. And they were like, you're using our tourniquets in rehab. Now this is, I don't know, this is like 2011, somewhere in there.
Okay.
So, some 2012 maybe. And so they go over
before like the popularization.
Oh yeah. Well, yeah, exactly. And so they go over and they meet Johnny, and Johnny kind of explains to them why they're doing this. And Delphi was like, well, I mean, we already have this device all set up. It can determine limb occlusion pressure. It can regulate that pressure over time. It's designed to basically be a surgical device, but we could retool it to basically do this rehab thing if you thought that was something that people were going to use. And Johnny was like, yeah, I think it is. And then it just kind of snowballs from there. NFL comes calling, ESPN comes calling. Johnny has to basically leave this really cush job within the Department of Defense and start his own company and kind of risk it all, if you will, to get this, to stand this thing up and make it become a thing. So, and then, somewhere along the way, I get involved. Gotcha. And that's how we get to today, I guess.
Right. And capitalism at its finest right there. Right.
Yeah. Yeah.
So then, you kind of tapped into it a bit here already when in that history, when you talked about kind of the physiological response of how BFR works and kind of the mechanism between applying it and how you induce muscle hypertrophy and physiological or metabolic changes at kind of a local muscular level. I have my stock answer of what I tell patients, but I'm curious, like for the average clinician that may not be as familiar, when you're applying it, how do you communicate that to patients to kind of get their approval, or what do you tell them the mechanism is in kind of layman's terms?
I tell them, I usually kind of ask them what they know, about muscle and why it gets bigger. And so, you try to have more of a conversation with a patient probably than I might just if I was up lecturing or something. So I usually kind of inquire about that and try to build my answer a little bit off of that. But I tend to kind of at some level discuss aerobic and anaerobic metabolism just because I feel like most people are kind of aware of those two things from science growing up. They're at least and a lot of people are familiar with like doing, got to get my cardio in or my aerobic exercise, get on the treadmill, that kind of thing. So I usually kind of start it from there and just basically kind of explain, your muscles that are aerobic are kind of your muscles that don't get very fatigued, but they also don't produce much force and they don't really adapt that much to stimuli and that sort of thing. And your type 2 fibers are your ones that contract quicker, more forcefully. They adapt to stimuli, and that sort of thing. And if you really get into the weeds, that's not a terribly accurate way of describing what's going on, but it for our purposes it works. And then and so then I kind of explain, what we've learned over time is it's actually not about lifting a big load and disrupting that muscle fiber and causing damage and having to rebuild it, which is kind of the narrative we all get taught. It's actually more about how much fatigue can you induce and making that muscle extremely tired. And then that fatigue sensation, which is also a failure sensation, if you will. It's just a different, it's not like a structural failure. It's more like, I don't know if conduction failure would be the right word, but it's more along that lines. This failure point is achieved. And, I just think of that failure point as you telling your body via exercise that it's not good enough and it's got to change. It's got to adapt to what you're exposing it to so that this becomes easier. And that's essentially what the muscle does. We take it to that failure point and it recognizes that signal as stressful. And I don't want to have to endure this if I, don't have to. And I can change and make myself more resilient and more robust so that, the next time this jerk makes me do this, it's not quite as tough. And then eventually joke's on him, I'm too good and, this is no longer a problem, which is why we have to progress exercise. So some kind of narrative like that. I've used analogies like a hybrid vehicle before where, I think of like a battery and a gas engine, and I really want to get into that gas engine. I want to run you out of this efficient energy and get you into this gas engine. And so basically, the cuff helps us do that because we don't let you replenish the efficient aerobic kind of energy, which we would like into a battery, and it forces you to get into the gas engine, and the gas engine eventually, the tank runs out at some point. So I've described it like that a lot too. But yeah, that was not so much a short explanation, but
I mean, I like the fact you kind of gave some clinical pearls there, right? As far as like different analogies and kind of bullet points to hit home to patients, right? That, like you said, may resonate a little better. So BFR, tons of applications, right? I mean, again, I know there's ongoing research about effects of blood flow restriction on bone health, right? On pain sensitization or sensitivity with things like tendinopathies, aerobic conditioning. But is it fair to say that kind of the most common application is kind of what we've alluded to, where you're trying to mitigate any muscle atrophy or impact things that way from a hypertrophy standpoint?
Yeah, I think that's fair. I think that's the best way that we use it. I think it's the most needed way for us to use it in rehab. The other points are, they're real things, but there's still a whole lot we don't know
Right.
about that. And I usually kind of, it's funny, Dan, like we always want evidence for things, like, well, how does this work with, this condition or that condition? And sometimes I think we miss the boat a little bit because from my perspective, I don't need direct evidence that this helps to, get somebody back quicker from an ACL reconstruction. And the reason I
Right.
say that is I know that this intervention increases muscle size and increases muscle strength if used properly.
Right.
And that is the deficit that I need to address for this patient to help them restore their function. So, you know, I need to be able to determine is it safe, and these other things. But in terms of needing direct evidence for specific conditions, I that's more of kind of like just being resistant to change to me than it is really sort of understanding how we function as clinicians.
Yeah.
So anyway, a
No,
little
I totally
soapbox there, but
I totally understand that. And I know
yeah.
I forget who I want to give credit to whoever it was. I think it's Charlie Weingroff was something that if you're a
Mm.
truly evidence-based practitioner, then you're probably like 10 years behind the rest of the
It's
expert
probably true.
clinicians, right? Yes.
It's
So
yeah. Well, I mean,
yeah,
number one, rehab studies are extremely difficult to do,
yeah.
and
And
there's
that's
not a lot of
where,
funding for them.
yeah.
Yeah.
I try to reconcile it because we'll get to it a little later in the podcast, but I know right now
Yeah.
evidence has been mixed with use of BFR and kind of efficacy in whether or not you do
Hmm.
expedite recovery post ACL reconstruction or that kind of thing.
Right.
But I mean, I feel like for anybody that's ever used BFR, like the fatigue is real. Like it's your leg feels like
Yeah.
lead when you put it on, right? That's not
Yeah.
like a placebo thing. That's
No,
so
that's a
yeah,
real deal. Yeah,
right.
for sure.
So I did want to get to that because I think, again, we in our practice we most commonly use it with post-op knees,
Hmm.
and I know there's a debate about kind of ideal time frame for implementation. In full disclosure, we will typically wait 2 weeks post-op just to allow wound closure and that kind of thing because I, mostly because I don't need an orthopedic surgeon screaming at me for inducing like an infection or that kind of thing in one of their, post-op knee patients, just to kind of mitigate the risk with that.
Hmm.
But in the research, and some of your work, is there kind of an ideal time frame? That's always my question is like, is my best window to implement BFR in that 2 to 6 week range? Is it 2 to 12 weeks? Am I better off waiting 6 to 12 when I can really start to load them heavier? Like, tell me, what is the kind of agreed upon efficacy window out there with BFR at this point in some of
Yeah.
those post-op needs?
I would say your best window to make the biggest difference is from day 0 to day 21.
Okay.
Um, we early on when we were teaching this, there was a whole lot of we don't know. There were very few post-op papers.
Right.
Very few orthopedic surgeons had really had any familiarity at all. And so early on, we were kind of on that sort of 2 week time frame of let's let that wound heal. Let's,
Yeah.
kind of like you were describing. That, as you can imagine, once like pro sports got involved, that timeline started to shrink real quick.
Accelerate. Yes. Yeah.
Within a year, I would say, we were down to within a year of getting this in front of a lot of really kind of elite people, we were down to at most people were waiting a week,
Okay.
if not like 3 days or so. At this point, I would say I really have zero inherent concerns about starting immediately post-op.
Okay. And is that kind of
Um,
that cell swelling protocol and,
yeah, you want to,
okay. Yeah.
yeah, and some people call it ischemic preconditioning. They
Right.
are different, technically, but I understand why people just kind of jumble those terms together.
Together. Yeah.
Um, but like to give you a for example, there's a recent study out of Germany with one of our colleagues, Alex Franz, who's an orthopedic
Okay.
surgeon, and they started day one post-op after total knee in the
Yeah.
hospital. Put the tourniquet on the thigh at 80%, had people do little quad sets just sitting there in bed. And then
Okay.
that eventually kind of goes to sitting off the edge of the bed. Can you do a long arc quad? Can you shift weight onto that leg with the tourniquet on? Can you maybe walk a little bit with it on, that kind of thing? So
Okay.
um, they the way they landed on day one is interesting. I thought we had Alex on our podcast, and he said we basically got all the orthopedic surgeons in a room and sat them down and said, "Look, guys, we got to determine when are we going to do this post-op, because there's no like clear cut, well researched sort of here's
Consensus.
when you
Yeah.
do it."
Right. Yeah.
And they said there's one criteria though. If you have an objection to a time point, you've got to substantiate that physiologically. You got to produce some sort of real risk that exists that we're aware of, or maybe we're not aware of and need to learn about, but
Yeah.
you've got to come up with that to be able to get us to push the timeline to a certain point. And he was like, basically, we couldn't come up with anything. Nobody could come up with any sort of physiological reason why we should be worried about putting this on people day one and getting after it. So
Yeah.
the wound healing thing, honestly, I don't know who first said it. I think it came out of the DoD, and it just people ran with that.
Latched onto it. Yeah. Sure.
Yeah, and I
Okay.
think it just kind of got out in the ethos, and people started kind of passing it along. Also, I think it's just the obvious thing to kind of point to. It's like, oh, well, I don't want
Sure.
the
Yeah.
wound to heal. But the reality is, like, man, we stick staples on these total knees, on these big, huge incisions, and they
Yeah.
swell up like crazy, but they don't dehiss.
Right.
So what are we really worried about here?
Yeah.
Obviously keep the field clean, don't cause an infection, as you mentioned. But I think we can
Sure.
do that and still put a tourniquet on
Oh,
and
for
not
sure.
worry about that too much. So yeah, so we go. And that's why I would say, kind of tailing into what you were talking about in regards to the inconsistencies in like the ACL literature. From my perspective, nobody started early enough and
Gotcha.
started with a program
Okay.
that really helps to address the problems that people deal with post-op ACL
Right.
early in the game, in a progressive fashion. Because I think what you can do, only because I've done it, is get this on people pretty quickly and get that quad back a little bit quicker, settle their
Right.
pain down a little bit quicker, so that they have less time pulling weight off of that limb. And that's the name of the game. If you can reduce how much time people are pulling weight off of that limb, I think that really helps ease a whole lot of the other problems that we have after ACL reconstruction. Do these people get back to sport sooner? I don't know. I don't know. I honestly, I kind of don't care. I just want to make people feel better as quickly as they can.
Sure.
And if this thing's gets people feeling better, restores their function a little bit sooner, then I think that's a win. I don't need it. They don't need to go back to sport faster. It'd be
Right.
awesome if they did, and probably a well-programmed thing gets you back. Program gets you back to performance sooner. But I'm more concerned about, can we just make that transition a little bit easier and a little bit more consistent? If we could do that, that would be huge. Because as it is right now, it's like we still don't really, it's just like, oh, just
Like,
wait longer. Well, nobody
no,
can wait 2 years,
yeah.
I
Yeah.
mean, nobody can do that.
No,
You
I
gotta,
hear you.
you know,
I totally agree. And I feel like that early post-op period, especially, I mean, again, if we're going to focus on ACLs, that early post-op period is like the most critical time window that
yeah,
really sets you up for success. I mean, we know that quad atrophy and some of the neural inhibition and that kind of thing starts within the first 48 hours, right? So I think the more you can do to mitigate that in that early post-op period, the better, right?
yeah,
To kind of more so prevent the loss of anything, especially, I mean, admittedly, one of our biggest populations that we use it with is some of the either when the ACL is done with a meniscal repair or an articular cartilage procedure, when there is some sort of weight bearing precaution, when
yeah,
you can't load them in a closed chain position, that kind of thing, right? The more you can do to kind of, like you said, prevent that loss of quad strength and to prevent atrophy, the better off you are, just to kind of set them up for success. And like you said, make them feel better. So, yeah.
100%.
So then just a segue from that, if you don't mind, my follow-up
Sure.
question is, with that protocol, if you're putting it on early, you mentioned that the orthopedic surgeons in Germany put it on at 80% limb occlusion pressure.
Yeah.
Do you have like a recommended, if you're starting it that early, do you have a recommended limb occlusion pressure that you start with in some of those post-op knees?
I will try 100% if I can.
Oh, wow. Okay.
Yeah.
Yeah.
I'll try 100%. So we tend to kind of think of loading and pressure having this inverse relationship, if you will, or sort of like a seesaw effect. So if, the person is unable to do much, then that means the cuff's got to do more. And so we're probably using a higher pressure in those situations. So I will oftentimes, it would depend on what I'm going to do with the person. If I'm just going to have them do little isometrics like
Quad
that,
set kind of things. Yeah, right.
I'm probably going to go 100%.
Okay.
If they're going to stand and kind of weight shift, maybe walk, I'm probably going to go 80%. I'm probably going to drop it down straight away. Because there's not a lot of evidence on people exercising at 100%. And it does have an effect on the cardiovascular system. But
Sure.
I mean, nobody's going to cause a cardiac event. I shouldn't say nobody's, knock on wood, but
yeah, right.
I mean, doing a little isometric contraction of the quad.
Right? Yeah, right.
Yeah, I don't think we're overly concerned about that. That person probably shouldn't be exercising if they're at risk for that. But yeah, so I usually kind of use those things to determine that. Reason I use 100% is the studies that have combined neuromuscular stim with BFR.
Yes.
The majority of them have used a pressure that's pretty similar to 100% or very close to it. So that's kind of why I land there as well, because those studies have actually shown in healthy, we can get people bigger and stronger through the combination. In an unloaded situation for 2 weeks, we can completely prevent the loss of quad muscle size. So those studies have demonstrated some efficacy there in terms of, the use of 100%. Now, has anybody tested it really closely to see what's better? No, that hasn't been done. So, obviously, if somebody can't handle 100%, I'll drop it to 90 or 80 or whatever I have to drop it to just get them to be kind of cool with it and start to lean into the fatigue. So if you think somebody's like straight away, I mean, you get a kind of a tester when you test their limb occlusion pressure anyway.
Yeah.
Because it goes full occlusion. So I always just kind of tell people, hey, I don't really even like this part of it. Like, to me, it just seems to get really tight, and most of the time people are like, that wasn't that bad, Colin. I'm like, well, I'm a pansy, like it's, you just kind of turn it around but you've got rapport there because you're like, you just told them like, well, you don't even really like it, but it's just kind of like this necessary part and it's quick. And then they're like, oh, that was no big deal. I'm like, great. Well, this next thing's going to be no big deal too, because we don't have to go that high. So that usually kind of helps work and, build some rapport and get you in there. And then, but if somebody for some reason doesn't tolerate limb occlusion pressure, then I'm probably not going to go 100% with them. I'm probably going to drift that down initially.
Gotcha.
The other population of people that I think you have to just be mindful of are those people that do not like having their blood pressure taken. There are people like that out there that really do not. In fact, it'll induce syncope in some people. They just don't like having their blood pressure taken.
Yeah.
Although I will say, I feel like it's an exposure problem. Like they just need to be exposed to it a little bit more. And so it's like, hey man, or gal, let's just put this on you. And you know what? We're not even going to go 100%. Like, I'm just going to give you 80 millimeters of mercury. It's like a gentle hug. I just want you to get okay with that. And then can we drift this up a little bit more? Let's just figure out at what point you're starting to just be like, I don't really love this anymore. And can we leave it there for a little bit and then deflate? And now we got a number, and now we can start gradually exposing that person to more and more pressure. And I honestly don't think it takes, I don't think you have to even be that fine with it. Like I just described, you can probably be a little bit more clunky and be fine.
Just play around.
But
Yeah.
yeah,
Okay.
I think you just have to be willing to kind of lean into, this person's probably not going to be able to do the ideal, rep, set scheme, pressure, load, all
Yeah.
of that straight away. That's your job as a clinician to get that person to that place.
Yeah.
That's
Kind of meet
why
them where they're at.
that's why
Right.
we get
Yeah.
paid the big bucks, Dan.
Yeah. I'm still waiting on that. Mine's been
I
deferred
know. That's
apparently.
why,
So
obviously,
yeah.
that's why I laugh when I say it.
Yeah. Yeah.
Yeah,
So I did have a couple of follow-up questions to that.
sure.
So tell me, you mentioned, at pressures that high, between 80 and 100%, is there kind of a max duration from a safety standpoint that you'll keep that on before you have to deflate the cuff, before we do anything detrimental or harmful?
Yeah. I would say your absolute don't go beyond is 2 hours, just
Oh, wow.
because
Okay.
that's what they do
All
in
right.
surgery.
Gotcha.
Like if you
Right.
think about it,
Yeah.
it's like they do more than 100% restriction in surgery for 2 hours.
Okay.
Now,
No, I mean,
obviously,
if somebody's in my clinic for
nobody's.
2 hours, I'm going to get yelled at.
Yeah,
So, yeah.
exactly. So, no, I don't think that there's a limit that I
Okay.
would put on it. I would say that, in the literature, it doesn't look like there's any reason to have that cuff on for more than say 20 to 30 minutes at
Okay.
a
That's kind of what I
given
was looking at.
at a
Yeah.
given
Okay.
time.
Okay.
And those types of exposures are usually like aerobic exercise where
Yeah.
they're walking or pedaling a bike
Or on the
or
bike. Yeah,
or
exactly.
something like that. But
Okay.
I would say, like, because I have to, I want to be careful when I say those numbers, because what some people hear is, okay, well, I can't use that tourniquet anymore in this session,
Right. Right.
and
Right.
that's
Yeah.
not at all what I'm saying. Like I routinely would have people do 4, 5, 6 exercises in a row, have that cuff inflated for 6 to 8 minutes for
Yeah.
each exercise, but I'm deflating in between. They're
In
getting a little bit
between.
of rest in between. So
Yeah.
they're
So
reperfusing a little bit.
is there an ideal like reperfusion window or, in between
You know,
exercises?
our device makes you go a 1 minute rest without being able to
Yeah.
reinflate.
Okay.
I nobody's ever looked at that. You
Okay.
know,
Yeah.
it's not something that's been well researched. If you look at the cell swelling studies, like you mentioned, those
Yeah.
studies use around 100% pressure for 5 minutes, and then they typically deflate for 3 minutes. Your ischemic preconditioning studies usually are inflated for 5 minutes and deflated for 5 minutes. Those are, the only studies that really even detail oftentimes rest period between sets where it's
Okay.
deflated. Most of the
Right.
other studies don't even really detail that, which
Okay.
I think I hate to say it doesn't matter, because it probably does at some point, but I think it's probably just so amorphous that it, in the grand scheme of things, if you're really trying to map everything out perfectly, sure, you want to pay attention to it. But if you just kind of stick to like at least like that 1 minute rest, which you're going to do anyway when you're
Right.
exercising intensely
For sure.
anyway,
Yes. Right. Even if you're just
So
segueing between two different exercises,
yeah,
right? Yeah.
exactly.
So, okay. All right. So conversely, is there, again, if like you mentioned, kind of adjusting it to that particular patient's tolerance, or you mentioned
Yeah.
just kind of giving them a hug, right? Is there kind of a minimum threshold that you need as far as limb occlusion pressure or that's been established in the literature to really get some benefit or to get significant benefit? I'll put it that way.
Yeah, I think at this point we'd say 40% is that
Okay.
number.
Yep.
That's straight from the methodology paper that Dr. Patterson organized in 2019.
Yep. Okay.
Um, Now, I think it probably, we typically kind of differentiate upper and lower extremity, because usually like
Yeah.
lower extremity, we're going to use somewhere in the neighborhood of like a 60 to 80%
Higher
pressure
pressures.
for
Yeah.
resistance exercise, because it takes that
Yep.
much pressure to get through the tissue. But in upper extremities, the indications would be 40% is plenty.
Yeah. Okay.
Um, So, I there's
Yeah, I should have
probably some,
differentiated. My bad.
no, yeah, it's all good.
Yeah.
I mean, there's a lot of details,
Yeah. Yeah.
in
Right.
exercise that we don't really think about.
Well, that's why you have the
Um,
course, right? That's
yeah.
a
So
plug for taking
exactly.
the course, right? Yeah.
Amen. Amen to
Yeah.
that. So I think maybe in the upper extremity you could potentially go a little bit lower, but people haven't really worked to kind of figure that out yet.
Yeah.
Ultimately, ultimately I would say if the pressure helps you move to a pressure that we know is effective, then it's great to use it. Please
Sure.
do.
Okay.
Um, but ultimately kind of your threshold to sort of figure that out would be, well, does this given pressure at this given load accelerate fatigue somehow? Is it
Yeah.
making this person get tired faster than they normally would? That'd be what we would kind of look for in the grand scheme of things. But
Okay.
I think it's probably reasonable to say, as if you're at a low load and a low pressure, that person's going to do a lot more repetitions than somebody that was at that same load, but increments higher pressure that we know is an effective pressure. And so then you're kind of going, well, do I want them to exercise for longer just because they can tolerate the pressure, or do I
Yeah.
want them to kind of lean into this and let's make this a more efficient sort of stimulus?
Gotcha.
Yeah.
All right. Yeah, and I don't. Yeah, I hate putting you on the spot for all these answers. Like,
No.
I
Yeah.
understand. Like I said, I just want to kind of give like rough parameters for, again, people that
Yeah,
may not be as familiar with integrating it into clinical practice. So,
for sure.
one other thing, Kyle, that I have kind of personally struggled with, right, is the intensity. Like, I think the common prevailing wisdom or the narrative out there is you want to work at like 30% ish, right, or so of
Yeah.
your one rep max, right? But I always find it hard, like, especially we mentioned the early post-op ACL, right? The person that can like barely do a straight leg raise, right? Or that
Yeah.
has trouble with a couple pounds, like, how do you program that for them going forward, as they progress with kind of determining? Do you have any hacks or suggestions for guesstimating or kind of recommendations for that progression criteria for them
To figure out the
to
load
figure out
in
30% or so of their
yeah.
one rep max for a straight leg raise, like I said, as they go forward, when this is a person that at like 1 week can like barely lift their leg on their own, that kind of
Yeah.
thing.
Yeah. I mean, the reality is there's probably a decent amount of time where you can't even get to 30% load,
Well, yeah,
and
that's what I'm
and that's
wondering.
and
Yeah.
that's okay.
Yeah.
As long as I always kind of tell people, I'm like, look, you got to know what works, like what is kind of ideal or optimal. But as long as you know that, then you can figure out, am I at that or not?
Yeah.
Usually, right? So, um, we use and what we would do in our clinic is we had this thing called the OmniRes scale. It's an RPE type
Okay.
scale,
Yeah.
and it just goes 0 to 10, and it's got a person or a guy like doing like a back squat basically.
Yeah.
And there, he starts at 0 and it's like super easy, and then 10 is like bars bending, plates on sides, that kind
Yeah.
of thing.
Right. Yeah. Right.
you
Yeah.
know and so you just
Veins are
show it.
popping out of the forehead. Yeah.
Exactly.
Right.
Yeah.
Yeah. Yeah.
And so there's probably like an AI version of that at this point, I would guess. That would
I'm
be
sure.
pretty
Yeah. Yeah.
dope. Yeah. Anyway,
Yeah.
I digress. So we would show that to the patient and just say, here's the exercise we want you to do. Give them a load that we knew that they could kind of handle. And we would say 0 is as light as this could possibly be. It feels like you're
Right.
not lifting anything at all. 10 is as heavy as this could possibly be. You can't imagine lifting anything heavier,
Yeah.
doing this exercise. And then have them do maybe 2-3 reps and ask them to rate the load that they just lifted. As long as they get kind of in that 2 to 3 range, that correlates pretty well
Okay.
to a 20 to 30% of one rep max.
Perfect. Okay. So you're just
From
kind of swapping out RPE for, you know,
yeah,
actually calculating that percentage. Okay.
yeah, that specific RPE. I think if we're too generic with RPE, people might think we're talking about the cardiovascular one, which
Oh,
is
right,
all
right. Yeah,
wonky. I forget
right.
what it's
No,
called,
yeah,
but
right. I got you. Yeah.
um, so yeah, that
Okay.
that particular
I guess
scale
we
is
could go
is
like reps in reserve or what? Yeah. Okay.
Yeah, I mean, reps in reserve would be something we absolutely would use once we have given that person a load and they've gone through an exercise.
Yes.
You
Okay.
know, so there's other things to kind of evaluate on the back end,
Okay.
but it ultimately you kind of got to pick something on the front end. Which is
Yeah.
the difficult thing. And so what we found was if we use that scale, we usually ended up with a load that somebody could handle and finish all 75 repetitions and feel like, wow, that was crazy. It was really hard to do, but I could do it. And it's fascinating how tired that made me. And, to me,
Exactly.
that's a huge win.
Yeah.
I mean, that first visit, you got to set the hook.
Right.
And if I crush this person with load or intensity or whatever, I didn't set the hook. I just threw a harpoon through their side. And the last thing they want to do is come back to this clinic because that guy made me do crap that I have no business doing. I
Yeah.
know I got no business doing it.
Right. Yeah.
Whatever it is. So
You want to see them for the follow up, is what you
yeah,
want.
I
Right.
want them to be
Yeah.
interested in what
Yes.
we're doing, and if they're interested, then you've immediately got buy-in, and it makes it that much easier to be able to incrementally push them a little bit harder, which we know we're going to have to do, but we don't
Yeah.
have to do it day one. You know.
Yeah.
And you're constantly teaching them. You're in their ear that whole time. I mean, I tell the story when I teach, because I have a case that I work through, and I had this post-op ACL guy, and I'd been working with him for 4 weeks or so, and we got to a point where he came in and he was like, "Hey, man, I know we've been kind of careful with this one exercise. We didn't want to load it too fast, that kind of thing. But I also know what you've been telling me with regard to like what I got to do to build muscle." He was like, "I can do more and I can control it." And I'm like, beautiful. You're doing my job for me now, man.
Yeah.
This is great.
Exactly.
This is exactly what we're chasing,
Yeah.
and so, that's when, that time you take early on pays off later stage. The patient, becomes not independent with it, but they start understanding like, okay, I got to work hard for this and I know it's temporary, but I can do it. And I need to help them see this because, we're moving slower than maybe we need to.
Yeah.
They're giving you permission to move a little bit faster. Um, so
Yeah.
that's cool. Yeah.
And I will say anecdotally that we had kind of touched on this a little bit before, but no, I won't say no one, but a very small percentage of people actually enjoy the BFR. But I would say percentage wise, like in that early post-op period, I have people that tolerate BFR way better than tolerate NMES or electric stim. So
Yeah.
I feel like the electric stim freaks way more people out than BFR,
Yeah.
especially when you titrate it or adjust it, like you mentioned it, to like a
Yeah.
level that they can tolerate. So,
For sure.
um, you had just mentioned it, and you beat me to my next bullet point that I
Okay.
wanted to kind of touch on with you, is kind of the ideal programming sets and rep scheme. Like I know kind of the recommendation out there in the literature is 75 reps per exercise, right? Which is
Mm-hmm.
traditionally, right, like one set of 30 followed by 3 sets of 15. But I know recently I've seen a few things out there, both in the literature and social media, about whether or not we need to be as strict or rigid with that template for the sets of rep scheme. So can you kind of tell us, delve into that a little bit and tell us kind of what your recommendation is as somebody that, is way more of an expert on BFR?
Yeah. You're right. You have seen that out there. It's funny
I
because
have, yeah.
I was texting with one of the authors of one of those papers yesterday, and he was complaining to me about a social media post that he saw where somebody had a cuff on someone and they were doing some sort of stretching exercise, and he was like,
Oh,
"Bro, what the?"
yeah.
And I'm like,
It kind
and
of
I
defeats
and
the
I
point.
sent back
Yeah.
to him, this is why I don't like the narrative about going less, just
Oh,
like
yeah.
clapping
Right.
all along the way.
Yes.
And he was laughing at me because we've kind of gone back and forth. Yes, the 30, 15, 15, 15 rep set scheme, it can be too much. Um, but not always.
Yeah.
And we
Right.
know it works. I always kind of like to know where things come from, and if you trace that back, 30, 15, 15, 15 ultimately comes from people basically doing 4 sets to failure.
Okay.
So 4 sets to failure at a given load and a given pressure. And on average, the sample does about 75 repetitions. So, instead of the split that they ended up in the literature, which was like 43, 13, 10, 8, whatever it is, they said, well, why don't we just take the 75 reps, spread it out? We know that volume of exercise works, and that's what we're after anyway, is volume. It spreads out 30, 15, 15, 15 really easily. We think that initial 30 really kind of helps to get rid of most of the oxygen in the system, if you will, so that then you're just kind of anaerobic for those last 3 sets. That's another kind of theory that's out there, but ultimately that's where it kind of comes from, is like 4 sets to failure. So I would say what's key is the person getting enough fatigue that they're pretty close to failure. We know that they don't have to go all the way to failure, but we need to induce enough fatigue.
Okay.
Right.
Yeah.
Yeah. We need to induce enough fatigue that they're close. So if you have somebody that's failing, before they get to all 75 reps, that's okay. That's kind of what we're chasing in the end.
Yeah. That's what you want.
And if you, ideally, I think it probably looks something like 30, 15, 13, 12 or 10 or something like that. That to me is a pretty good split, and you can go from there. But the literature you're kind of talking about specifically has shown, it looks like maybe even just 4 sets to 15 can work.
Yeah.
Now mind you, and this is something that I know specifically Jeremy Lineker has mentioned just kind of in conversations, is these studies where they get these results, they're in a lab setting with healthy people, with multiple people around them encouraging them to go, 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 like in their ear. Not something you're typically going to see in a PT clinic. Like, how many times is a PT in a patient's face going, "Come on, you pansy, let's go. You got to lift this freaking weight." We don't do that, No. It's not that you couldn't with some, but we don't do that.
Yeah.
And so, I think there's some important nuance that needs to get kind of layered in there before we just say, oh, well, the 4 sets of 15 could work. Yeah, I mean, it might, but not if they didn't get tired enough, not if that muscle wasn't fatigued enough. To stick on that same narrative, though, in terms of can you do less, there's another study that I know is coming out specifically from the guy I was texting with yesterday, where they did a single set to failure. And on average, people did about 60 repetitions. And they did this in a longitudinal study and saw similar increases in muscle size, muscle strength.
Okay.
Great.
Yeah.
I've worked with a lot of people. That's a lot of reps.
That's 60 is a lot.
Given load, I'm not saying they couldn't do it, but I just, because I never tried it, but it just sounds a little kooky.
A little sadistic,
and I think, I think some of this stuff becomes academic, and we need to kind of keep it in that space for a while until we figure out, what is the best way. I think 30, 15, 15, 15 is on the higher side of the volume. But, we also kind of know it works. And, as long as we kind of have our eye on the prize of, I need to make sure that this person's muscle is really tired, that this person's working very, very hard. And then we're at least kind of in this window of loads and pressures that we know work, then I think we can kind of be pretty satisfied with, somewhere between whatever 60 and 80 repetitions, something like that.
Sure.
Yeah.
All right. So my next question, Kyle, I keep seeing more and more the emergence of post-op protocols for hip arthroscopy using BFR, and some shoulder protocols using BFR. And for me, I can easily wrap my head around the physiological effect when you are applying it for muscles that are distal to that cuff. But can you kind of clear up, what do we think? And I will give the disclaimer that, like I said, when I've taken a BFR course and done hip abduction straight leg raises, my glutes are burning and it's doing something, right? But I'm wondering if you can kind of clarify, what we think from the research or from the literature out there, what the mechanism of action is for the muscles that are proximal to that cuff. How does it work with them?
Sure, definitely. I'm gonna take a little bit of an aside where I start here,
Okay.
just because it's not a pet peeve of mine, but like it's just something that I'm passionate about making sure physical therapists think through and understand. And that is specifically within like the hip arthroscopy population. Don't forget about the quad
Right, right. Yeah,
because
sure.
this
Yeah.
the so we absolutely might be
No,
using
yeah,
BFR early on to
yeah.
address those muscles below the cuff because here's the thing, the moment you start pulling load off that limb, so that means the moment you start having hip pain, you have a disuse stimulus that's going into that limb and it
Right.
heavily affects the quadriceps. We know
Yeah.
that. We like
And
science
especially
has
rectus femoris, right? I mean,
y-
that's like
y-
the hip, the muscles that flex the hip are the ones that we see
yeah.
get the weakest. Well, not, I mean, again, that's debatable, right? But there's a huge impact on hip flexors. We'll see that, right?
Yeah, yeah, but
Yeah.
even just the unloading stimulus specifically,
Yeah.
will I would think rectus femoris is probably kind of tied not only to that but also to pain
For sure.
generation.
Yes.
So that would be like especially on the hip why you would see that one heavily affected. But I mean, we know from healthy people just immobilizing their limb and making them non-weight bearing, the quadriceps and the soleus are going to atrophy the fastest. We can
For
actually
sure.
predict how fast the quadriceps is going to atrophy and tell you how much muscle you're going to lose over a given time point. So this is well-established science. This is science that, if you're not applying as a physical therapist, I think you need this as a big time level up for the care that you provide for your
For
patients.
sure. Yeah.
So, I think making sure that we are going after quad, gastroc all that kinetic chain in your hip arthroscopy people and going after it hard is an extremely important piece of that rehabilitation process.
Yeah.
Because how good is a hip going to feel if your quad and your gastric soleus complex can attenuate the ground reaction forces that they're being exposed to just from ambulation?
Yeah. Right. Or if you
That at
can't
some
get to
point
that
that
triple
load can't
extension
work its
position,
way
right?
up
Yeah.
the
Sure.
you can't work its way up the chain anymore. So it starts
Yeah.
pissing off that joint. So let's make sure that we can address those, that people are going to be experiencing. So that aside, getting into, well, how does this work above the cuff? We for sure, I think the most logical understanding comes from using multi-joint exercises like a squat or a bench press or like a lat pull. And what happens because of the cuff being applied is the muscles that are involved in that movement distal to the cuff start to really fatigue.
Yeah.
And because those muscles fatigue, you start to recruit the muscles above the cuff faster than you normally would. So, and that's been actually shown through EMG studies that are longitudinal to where, you have somebody do a bench press and with and without BFR, and you see them start recruiting the pec much earlier when they add the BFR. So we know that that angle works. We have evidence in the, like I said, in the pec and the glute. I don't know if there's actually evidence in the lat, but I think it's just kind of logical. It's the
Sure.
same kind of principle. We could infer that most likely. And I will tell you that when I did pull ups on the total gym with BFR, my lats have never been more lit up than that. That was wild.
Yeah.
But anyway, I digress. So that theory, we call it downstream fatigue. Basically, fatigue of the muscles distal that gives us access to the muscles proximal with these multi-joint tasks. That
Okay.
still doesn't address all the muscles above the cuff that we oftentimes have to work with in rehab, though. Specifically, you think about like rotator cuff,
Yeah.
intrinsic hip muscles, that kind
Hip
of thing.
rotators. Yeah.
Yeah,
Sure.
those muscles, we think probably there's some sort of backflow effect that you get. And the easiest way to describe that is thinking of like a funnel and, pouring liquid into a funnel and how you kind of get kind of this backing up of
Sure.
liquid.
Yeah.
So, and that makes sense kind of in your head. Whether or not that actually happens, nobody's actually truly tested that. But it sort of makes sense. And, we do have some indication that, like, for example, in the shoulder specifically, a 50% pressure really gets us optimal recruitment through EMG of some of the rotator cuff muscles or muscles that are at least close to the rotator cuff.
Right.
Um, so I think that is one mechanism how BFR might work above the cuff. There's honestly, I mean, when you really look at the evidence for muscle specifically above the cuff, there's very little out there. So we have people like yourself, that have done this, and they're like, well, I can tell it's working above the cuff. This is not an issue for me. I'm
Yeah, it's
obviously
not
getting tired
imagined.
here.
Yeah,
Yeah.
right.
I
Yeah.
just am curious why. That's the one thing, the one theory that kind of explains why is there must be some
Okay.
sort of like retrograde kind of restriction above the cuff.
Sure.
The third explanation that is out there is maybe there's something systemic going on. That is much harder to kind of nail down than any of the other
Sure.
two
To
in
prove.
terms
Yeah.
of
Okay.
what do you have to do to elicit that systemic stimulus. I mean, you will hear, as I have heard, people claim that, oh, I can do rotator cuff exercise on one side and prevent atrophy on the other side, and that has never been shown in a study. That does not make physiologic sense.
Yeah.
If you've seen that, great, but it's not something that is a known physiologic response at all. So never mind. Like, are we really thinking the systemic effects of the infraspinatus and Aries minor is huge? Like, give me a
Yeah.
break.
Right.
It's like sufficient, and it's only going to target. Systemic effects means it goes everywhere, mind you. So it's got to go everywhere, and then
Yeah.
hit. So I think I'm going to lean on systemic effects of like lower extremity exercise before I rely on systemic effects of
That's
rotator
fair.
cuff
Yeah.
external rotators.
I
If
think
I'm
we're in agreement on
you
that
know,
one. Yeah.
like
Yeah.
if we're just kind of thinking about this a little critically here.
Yeah.
Um, so yeah, it's probably a backflow effect or some sort of like downstream kind of fatigue, but I think there's more to come on that front. Like
Yeah.
there's a lot we don't really know. I'm not really sure how we tease it out personally.
Yeah.
So I don't push people real hard to work on exercises like that are above the cuff. I'm like, yeah, hey, go for it if you can. My personal experience with shoulders is I feel like I spend a bunch of my time just trying to settle the thing down and get the range back,
Yeah. Yeah.
and
Yeah.
and by then it's like, well, we probably can load it at that point. We
Sure.
there wasn't really any opportunity for light loaded exercise to try to prevent that muscle from getting weaker or address the strength deficit sooner, sort of thing. So
Yeah.
but that being said, like that was just the population of shoulders that we saw through our clinic. There's plenty of shoulders out there that rehab faster than that, and that you could probably do this with. So
Sure. Okay.
well,
You mentioned it, a minute or two ago, with using BFR with these multi-joint exercises, right?
mhm.
So I wanted to find out from you, again, from the evidence or the literature out there, is there a difference in the potential benefit or carryover effects when using BFR in closed chain, like a more functional position versus your basic kind of non-weight bearing table exercises, that kind of thing, especially with lower extremity. Yeah, since we're kind of primarily focused on that right now.
um, I would say that it really depends on what muscle you've identified you need to address.
Okay, that's fair. Yeah.
If you are, trying to get the quad bigger and stronger, the best exercise is the long arc quad.
Sure.
There's just
Because it
not,
isolates it. Sure.
it
Yeah.
isolates it. There's just no
Right.
escape for it,
Yes.
Same would be for hamstring, bicep, tricep, all of that.
Okay.
If you're getting into the glute, now it's, maybe you're doing some hip thrusts,
Yeah.
some squats, some leg press, maybe you're varying, hip position, foot position. There's a lot of different things you could kind of try.
Variables. Yeah.
On that front. I don't know that. I mean, I would think that I'd be trying to perform an exercise that mimics the ideal action of the glute max. So some sort of hip extension, abduction type motion would be what you'd really kind of be after. So
Right.
that would, favor something like a hip thrust with a band maybe at the knees or something like that, maybe.
Okay.
Similar with like a squat type movement, I guess. Um, but yeah, I would try to find the exercise that isolates the muscle
Got it.
the
Okay.
most. So,
Yeah.
I think, just what we have learned from rehab over time, especially around the knee, is, if you got some knee pain, the knee's going to try to avoid you from using the quad because the quad is what
Sure.
loads that joint,
Yeah.
And so,
Your
and
brain
we're
gets good at compensating and cheating,
yeah,
right?
it's really good
So
at it,
yeah.
So you kind of got to force it to engage those regions by, what we would say is by constraining the environment. You have to,
Yeah.
constrain the exercise such that the only escape is for the muscle you want to work for it to do its job, and then you got to figure
Right.
out how do you load it? How do you make it tired?
Yeah. Okay. That's fair. Um, we've been kind of primarily focused, right, on like the kind of traditional like post-op considerations for BFR, Kyle, but
Yeah.
I know again BFR is being applied in many applications other than just post-op rehab stuff. So
Sure.
tell us a little bit about using it, especially because tendinopathy again is something we're seeing more and more in our understanding of tendinopathy and how to treat it continues to evolve and get better. Tell us implementing BFR with tendinopathy, where you're focused more on the pain modulation and maybe isometric, utilization in conjunction with isometrics. How does it change using BFR with that versus in your basic post-op patient?
Um,
Does
I
it
would,
change? Yeah.
yeah, I would
Yeah.
say that I am going to try every possible loading option before I go to BFR.
Gotcha. Okay. So
Whereas
isometrics,
in
eccentrics. Yeah. Okay.
yeah,
Yeah.
heavy slow isotonics,
Yep.
I think that the more because tendinopathy, like a true tendinopathy, you're talking like a 4 to 6 month process
Right.
to remodel all that tissue.
Okay.
So I want to get somebody as independent as they can be as quickly as I can get them because especially in the lower extremity, I want to be able to kind of oversee that person to the point of, jogging, running, cutting, jumping, etc., if they want to do those things.
Sure.
And all of those progressions along the way are just going to take time and they're going to require my skill at it, reasoning through movement.
Yeah.
Um, so I would say I try, eccentrics, heavy slow, isometrics, low, moderate load, resistance. Can I
Okay.
get the person to do any of those things and get some progress along that route? Then and not even have to use BFR.
Okay.
So BFR
Gotcha.
kind of becomes my man. I have not been able to figure out how to load this person,
Gotcha.
or I
Right.
just
Yeah.
got a hunch that man, it seems so irritable that we're gonna have to go this route, kind of thing.
Sure.
Um, and the only reason for somebody might ask, and it'd be a logical question. Well, why not just skip the steps, Kyle? Why not just try BFR first and see if it works, and then do all the other stuff? Well, I just don't want them to get dependent upon the BFR. I don't want them
Sure.
to get
Okay.
too dependent upon thinking that they need this thing because we know people do that.
Oh, for sure.
We
Yeah.
see it
Any
with
modality, right?
massage,
Yeah.
ultrasound,
Manual
like
therapy. Yeah.
like
Right.
people don't like BFR. It doesn't mean they're not going to get dependent upon it.
Yeah.
So I want to try to avoid that if I can. Um, so that's usually kind of the angle I go. And I feel like the tendinopathy literature really supports that at this point. The tendinopathy literature I feel like is just saying, just get it some load some way, shape, or form kind of
Right.
thing.
Tendons love load. Yeah. Sure.
Yeah, tendons love load. Now, whether or not they actually need load to adapt, I think to me is questionable in particular because there are at least 2 or 3 different papers now in BFR showing patella tendon, Achilles tendon increases in stiffness and size with low load in BFR
Yeah.
compared against heavy load and seeing there's no difference between the two. But I also think that we sort of forget that lower extremity tendons accept way more load than we can physically give somebody in a machine.
Right.
Like you're talking 6 times body weight when you run at the Achilles. Ain't nobody doing a heel raise at 6 times body weight in the gym.
No.
That ain't a thing. The only way you get there is you add velocity and mass,
Right.
And it's for kind of that short window. So I think, when you put loading in that context, BFR at 30% load and heavy slow at 60 to 80% load, they're a lot closer to one another than 6 times body weight is.
For sure.
Like, so
Yeah.
when you actually contextualize load with respect to lower extremity tendons in particular, I think BFR is a whole lot closer to the loading parameters of heavy load than it is to what those tendons routinely deal with when we are physically active, sort of thing. So,
Yeah.
so I think keeping that context is kind of important as well.
Okay.
But I also think just obviously move towards load, because there's a lot of ways to do load. Whether at your own gym, at your home gym, in your house, on your stairs, whatever. And not
certainly
in the
you
clinic.
want to give that patient like a strategy that they can do, like you said, independently, where they can kind of self-manage, right?
Right.
Yeah. I just didn't know. Again, I've seen some things out there about the effects of BFR on pain sensitivity and pain modulation and some of the effects that way, and if it helps as like an adjunct from that standpoint.
Yeah, I mean, it's logical that it would, and it's certainly been suggested to use it that way. So I think that's a perfectly fine way to do it.
Okay.
I just probably wait a little bit to go there.
Yeah.
Then go there straight away. Yeah.
Yeah. So if we kind of branch out, since it's rehab exercise and sports stuff, on the performance side of things, right? One of the things I feel like, as physical therapists, maybe we're not as comfortable with, or that kind of thing, is using BFR from like an aerobic capacity standpoint or recovery and that kind of thing. So tell us, if you can, a little about some of the other BFR applications and efficacy that way.
Sure. Yeah, I think one of the things that's really underutilized is like walking or pedaling a bike with BFR. I specifically in like your traditional outpatient clinic where you're going to have a decent amount of older folks. I started just finishing off visits with like 10, 15 minutes of just BFR combined with cycling. Because it has some angiogenic effects, some endurance effects, and some really positive kind of effects on muscle. So I found that to be a really kind of easy way to sort of finish off a visit and make somebody just get some good work in. So there's that aside. But in the sports realm, yeah, I mean, from an effects sort of perspective, we have evidence now showing as early as like 2 weeks, we can see improvements in VO2 max by about 6% with exposure to just BFR walking or BFR cycling. And that fast of an adaptation is a function of this person was exposed to exercise daily, to this stimulus daily, and just because it's such a light load and a local kind of effect on muscle, blood flow, etc., it's not creating enough stress to where there's a big recovery time, sort of thing. So, but if you do the same stimulus, so just like walking on a treadmill for 20 minutes with BFR both legs, you do that 3 times a week for 20 minutes. And at a month now, we see a 6% improvement in VO2 max. So it's just a matter of how quickly you want or need to get to where you're going with what you're doing. So I think that is, and that's something that we've been really kind of pushing on teams recently, because just about every sport, you need some level of endurance and fatigue resistance and that sort of thing. And certainly the legs are usually the thing that's kind of pointed to. But there are also ways to kind of feather in BFR resistance training into like a traditional kind of strength and conditioning sort of programs. So just replacing some like simple accessory exercises is a very kind of simple way of doing that. Um, I kind of look at BFR as a way of adding volume to an already highly trained individual that's hard to kind of get them to the next step, but can I just add a little bit of low load stimulus? And yeah, they have to exert themselves, but in the end, we're kind of talking about like a 5 to 15 minute window most of the time. So it's not like a huge ask. Um, so there's that way of looking at it. I think you could also kind of look at it from the perspective of, hey, this is a long season. We've got this kind of tight window where there's a ton of travel and, a lot of stuff kind of, people got tests and whatever. And so let's just kind of make this week a BFR exercise week, and maybe we kind of shrink all the strength and conditioning down into a shorter ask for an athlete so that, we're removing stress from their lives because they're not in the gym as much. We're removing stress from their bodies because they're not physically having to load their tissues as much.
Super heavy.
Yeah, and we're still giving them a stimulus that is at least going to just kind of keep them status quo, if you will.
Beneficial. Yeah, exactly.
Yeah.
Sure. Okay.
All of those have a real kind of effect on recovery. So anything you can do to make somebody more robust, more resilient, is going to affect their recovery. But you said specifically recovery, so that's why I bring it up.
Only because I keep seeing more and more teams that are implementing it into that whole like post-match recovery process, in conjunction with a lot of other things, right? But I know again that's like an emerging area, so that's why I ask you.
Yeah, and there's a decent amount of evidence at this point. It's people use the ischemic preconditioning then is what's specifically used. So it's 5 minutes full occlusion, 5 minute deflation for 3 rounds, typically done immediately like after an exposure. And the results that we see are less soreness, so less DOMS generally, and a quicker restoration of neuromuscular function, typically assessed via like a strength or a power assessment. And that's been affirmed in 5-6 different studies at this point now. So and I will say athletes just tend to really like how it feels. They like the deflation. It feels good, and so that is an added kind of bonus to if we have evidence to kind of support the use of this, and also the athlete tends to like it. The real question mark that's kind of out there with regard to IPC and recovery for me is at what point does it its effectiveness kind of diminish? Are we really just kind of mimicking like a repeated bouts effect ultimately that any trained athlete's going to bounce back from quickly? I think that's a possibility, although there is some research that would that's done on trained athletes still showing them recovering that would push back on that narrative. Or can we layer in the use of IPC or BFR just throughout an athlete's kind of week or whatever, so that they get the effects and don't necessarily have to do this right after the game, etc. Because what's interesting about IPC is there are multiple kind of protective windows that are described. So there's one that happens kind of immediately after, but then there's another that happens beginning around 24 hours later and another beginning around 48 hours later.
Okay.
And so what's thought is like maybe you can kind of get those guys overlapping and make the recovery process even a little bit quicker. And that was shown with a single study. So we know the windows kind of exist, but in terms of how best to use it, still being kind of teased out.
Still ongoing. Yeah. Okay. So that's a good segue into my next question for you, because I could sit and keep you on here all day.
Yeah, all good, man.
I don't want to monopolize too much of your time.
I literally talk about this all day.
I have my own personal questions. I could get in all kinds of a nuance, but I want to be sensitive to your time also.
Got my phone number
So
down, man. You're good.
on that note, right? Tell me, like, what do you think is the next step? I mean, we just focus on the performance side, but for our listeners, I want to kind of bring it back to the rehab side if we can. Tell me what you think is kind of the next step or the research gaps right now on BFR use in rehab. Like, what are the key questions we still need to answer?
I'll come at this from two angles. One
Sure.
that's more applicable to a lot of the outpatient folks, and the other one that gets my juices kind of going.
Sure.
They both get my juices going, but one more than the other. On the standard kind of rehab side, like traditional outpatient, I would say from just like a total knee, ACL, total hip perspective, really figuring out how best to expose people in a prehab fashion and then early post-operatively.
Yeah.
Like, can we develop some kind of a construct that people at least can kind of work off of to make those recoveries better? And I think there are some distinct things that we can accomplish if we figure that out. I think what we can do is we can actually have an effect on people's post-operative pain. I think that we can have an effect on how much muscle they lose. And I think that we can have an effect on how quickly they get back to basic daily functions with limited limitations. So that's on the traditional rehab side. Those are the big gaps that I see. And all of that, of course, depends on people programming this well, et cetera, et cetera, et cetera. But if we could develop some sort of a framework for people to work off of that makes it easier to understand, that'd be great. And
hopefully this today helps, right, to kind of further that.
Exactly.
Cause, right? Yes.
Exactly.
Yeah.
On the grander picture, sort of looking at physical therapy from the whole profession, if you will, I think the neurologic patients are the ones, and then the older patients are the ones where I really kind of get interested in how much we can help them. The neurologic space has been very interested now for about 3 years or more. Got a lot of different folks that work in those spaces using BFR with people with post-stroke or multiple sclerosis or Parkinson's or spinal cord injury, and really saying, man, we've been able to increase people's function. We've been able to increase their independence. We've been able to reduce some of their pain. There's a study that I actually was fortunate enough to get to help with on Parkinson's disease, where they helped address people's heart rate variability and restless leg problems that they would have at night. And the people that were in the BFR cohort were like, we don't want to stop doing this. It's really helping us feel so good,
Yeah.
And those are the, and that's the kind of shit. Sorry, but
all good.
That's the kind of shit that doesn't come through in a research paper. And this woman that did this study who got published in the Journal of Parkinson's Disease or whatever it is, a really nice journal, showed these great things. But the thing that the paper doesn't show you is she went back and she interviewed all the folks that she worked with, and the reports from them of how much BFR helped them just not lose their freaking minds over just, their physical condition was incredible to read, and like we're reading this. I mean, I got to see this stuff like 3 years before the paper was even published, because some of this stuff takes that long, and you're going, this is incredible, And these are the things that we get to experience as clinicians, in our spaces a lot of times that just doesn't come through in the literature. And we get frustrated because it's like, yeah, but we know this and this and this and this, but the paper's like, well, but back pain, blah, blah, blah,
I understand.
So I just think that the positive things we can do for people who really have a much larger need than the ones that, not that people don't have a big need that come through our doors in outpatient physical therapy, but the impact of being able to help those folks is seemingly much larger and more important in some respects. So I think it's cool to see BFR working into those spaces. And I look forward to a day where, like every physical therapist, even maybe nurses, and this is ubiquitous throughout hospital systems, to where we're really prioritizing people's muscle mass and their function. And we're all kind of working as a cohesive unit to address that. And BFR is just kind of one of those things that we have in that bag of tricks to kind of help us, help those people.
Yeah, it kind of becomes more standard of care. Yeah.
Yeah.
So, all right. Well, so on that note, then tell us, for you personally or with Owens, Kyle, what kind of projects or things do you have happening professionally in 2026?
So our big push right now is we are working on a new website and then an educational app. So we'll have very soon an app that will have a lot of our course content on there. A lot of content from other colleagues that we just have gotten to know through the years that we'll bring on. The idea is to have just like little, 10-minute-ish video segments that you can just kind of go into the app and watch and get a little bit of education and kind of that short time frame that you might have, whether it be between patients or, on a weekend and you just want to nerd out or whatever it is.
Yeah.
So we've got that on the horizon. We have, crazy enough, we have a new course on BFR throwing that is making its way kind of into Major League Baseball right now. So we've got a guy that has been messing with that for the last 3 years or so, just using it on his own personal clients and really just kind of consistently getting good results. So we are kind of rolling that out and seeing what lands. There's no good evidence on that. We don't really know why it works or anything just yet, but if it works in a similar fashion to resistance exercise, whereby you can induce more fatigue at lower intensities, then that might help us control how much pitchers have to throw and that sort of thing, and leave them more time to be able to throw during games. So that it's kind of one of the potential sort of upsides on that front.
For sure.
So that's an interesting piece that's kind of out there and forthcoming. And then we are, always working on improving device side of things, trying to make it more accessible, more reliable, more evidence-based, all those things that you want out of a device that you're going to spend some money on. So those are kind of the big things on that front. Nothing really. I'm trying to think if there's any just sort of research. I think we're just mostly kind of leaning into the research on the baseball throwing and seeing if we can get some projects going on that front to try to help us understand what exactly is going on and why.
What the mechanism is. Yeah. Right.
Yeah.
Well, I mean, I always tell people, like, whether it's real or whether it's placebo, I mean, if the person's getting a benefit from it, right, that's ultimately the bottom line, right?
Yeah, exactly. Yep. And the big thing is do no harm. So
yes, exactly.
Which, fortunately, like no adverse events so far. And I've gone down the wormhole of reasoning through what should we be concerned about. And I kind of keep coming back with, I don't know that there's a whole lot to be concerned about here. So
awesome. All right. Amen. Well, I can't thank you again enough for your time. I'll make sure, Kyle, we include any links to what you have going on course-wise with Owens for any listeners that might be more interested. Any educational stuff that you want to disseminate in conjunction with this, we'll make sure we circle back and get all those included in the show notes. But awesome. Thank you again for all your time here today. I know I got sucked in and probably went a little more than either of us had planned. But it's all good, dude. This has been awesome. Yeah, great. No, fun talking to you, Dan. Appreciate you having me on, and thanks to all the listeners. Yeah, awesome. All right. Thanks, Kyle. You bet. Have a great day.